All right. Well, welcome back to Ultrasound Grand Rounds this week. We are nearing the end of our academic year. We have a couple weeks left, but we have some pretty good, pretty solid, pretty exciting topics that we want to cover before we finish things up for this year. And today is going to be one of those topics. We've been doing a little mini series kind of scattered over the course of the winter and the spring this year, but talking about OB ultrasound. We started off with a normal first trimester, talked about a nearly normal first trimester, and then we talked about abnormal first trimester. That one was given by Sandy last week. She did a spectacular job. That's going to be posted here on the YouTube channel momentarily. But today, to kind of wrap up this whole OB series, we are going to be talking about second and third trimester emergencies. And for that, we've invited on Dr. Kelly Gibson, one of our OB and MFM specialists, to the forum today to talk to us a little bit about OB second and third trimester ultrasound. But before we get to that, Kelly is one of our, like I said, our maternal fetal medicine physicians. She did her residency here at MetroHealth. She did her fellowship here at MetroHealth, and now she's one of our spectacular faculty here at MetroHealth and one of our ultrasound experts when it comes to OB ultrasound. In addition to all of those things, she's also the site director for MetroHealth for a consortium of OB researchers. I think she's had about 14 different hospitals that are involved in this consortium. So she's our research site director. So all those hats keep her definitely very, very busy. And I appreciate her taking time out of clinic today to talk to us about second and third trimester ultrasound. So with that being said, let's switch on over to Dr. Gibson, switch on over to her slide set, and learn a little bit about how to assess and manage the second and third trimester ultrasound or OB patients with ultrasound.
All right. Well, thank you very much for that introduction. I'm excited to be able to join you all today and share a little bit about what I spend a lot of time doing, and that's second and third trimester ultrasounds with a specific focus on some of the emergency type of cases that you might see walking through the doors. I do not have any disclosures to share today that are relevant. My objectives are really first just to cover some of the 6 fundamental components of a point of care ultrasound in the second and third trimester exam. Then to describe some of the most common OB emergencies that you might see come through the ED, and then finally to explore how to utilize ultrasound to care for women during these emergencies. So when you come in, a patient comes in and they're pregnant and you're going to do an exam, there's a couple basics that we want to cover. First thing that I always want to know is how many babies are there and how are they presenting? What is their lie? And a fetal lie can be either longitudinal, kind of up and down. So most babies will be in a longitudinal lie, whether that's cephalic, meaning the head is down, or breech, meaning the butt is down. They may be transverse, so kind of laying sideways, and we can see this especially if there's a multiple gestation, or perhaps if there's a large fibroid, something that's preventing the fetus from being in a longitudinal lie. And then if they're in between, we call that an oblique lie, meaning they're not quite longitudinal, but they're not quite transverse. They're just in between. So when we start a scan, I always want to know where is the baby in relation, specifically really where is the head? Is the head up or is the head down? And then we can move on to the next part of the scan. So as examples, so like I said, the majority will have a longitudinal lie, either breech or cephalic. This would be an example here where this is the patient's cervix and this is the fetal head. So you put the ultrasound probe down and you say, okay, head is presenting. If you put the probe down and you have a picture like this is not a head, this is baby's butt. So this would be an example of breech presentation. Next thing I want to know is what is the cardiac activity? Ideally, we would obtain this by looking at a 4-chamber view of the fetal heart. So to get a 4-chamber view, it's a little trickier in a fetus than an adult, where you just say lay down and the heart is in general where you expect it to be, right here on the left side of the chest. But in a fetus, the fetus could be in any position and might be spine up, might be spine down, might be laying all curled up. But ideally, you could get a view like this where you can see all 4 chambers. And then you want to use M mode in order to place that caliper just directly here through one of the ventricles in order to get the fetal cardiac rate. If you don't have M mode available, sometimes on labor and delivery, we'll just say tap, 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 and have a nurse kind of count how fast we're tapping if you're trying to quickly assess the fetal heart rate, especially if you have an ultrasound that maybe you're not familiar with, or you don't know where the M mode button is, or you can't figure out how to go from M mode to calculating the fetal heart rate. That certainly happened to me when I get called into an emergency, maybe in a different setting than I'm normally in, and I don't know the machine. Tap, tap, tap works just as well in an emergency to say, is the fetal heart rate normal, meaning 120 to 160, or is it really slow? So if you're saying tap, 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 hopefully your OB team is on the way because that baby should be delivered soon. This is just a video here just showing you how you might kind of scan through in order to obtain that 4-chamber view. You can see you kind of work your way. Ideally, you start through the belly and then just angle your probe slightly up into the chest in order to get that axial view. So once you've established fetal lie, heart rate, we need to know fetal number. About 1 in 30 to 40 births are twins. Much less common are triplets or even higher order multiples. So often if you're going to see a multiple gestation, it's going to be twins. And I know you've already covered kind of first trimester unusual cases where you might find twins, and determining chorionicity of those twins is most easily done in the first trimester. As they get bigger and bigger and the fetuses are pressing up against the membranes, it can be more challenging, but it's still possible. And the different kinds of twins you can see are kind of shown here. So monochorionic twins, there are no membranes separating them. They're both within the same sac, just both cords coming off that same placenta. These are the least common twins and also the most likely to have complications because, as you can imagine, as those babies rotate around, their cords get all twisted up. Next is monochorionic diamniotic, where there is a thin layer between them. However, they still share a placenta. So these twins can get into trouble where they don't share that placenta equally. And this is a case where you might see one very small twin and one very large or even hydropic twin. Next, and this is most common, is having a di-di twin. So dichorionic, diamniotic. So 2 sets of membranes around each of them. Sometimes the placentas are right next to each other, so it can be a little harder to tell those between the monodi. Sometimes the placentas are completely separate, maybe one anterior, one posterior. Either way, as long as they each have their own full set of both layers of membranes around them, then that's considered a di-di pregnancy. When we scan them, we want to know their number, and then we want to know their location in relation to really where they are in the pregnant patient. So are they both cephalic? Are they on the maternal left, maternal right? Is one transverse? That's how we would describe the presentation for twins. When we're looking to evaluate whether it's a monodi or di-di, what you really want to look at is the insertion of the membranes. We call it the lambda or the T signs. And you might have covered this in your first trimester ultrasound, but here when you look, this is a thick membrane. The thicker the membrane, the more likely it is that it's a di-di pregnancy because you have 4 layers of membrane there. Conversely, when it is a monodi, placentation, you have a very thin membrane here, and that's because there's just 2 layers of membrane there. And you can see I can overlay. This is the lambda sign versus the T sign where it's very narrow. Next thing I want to know is the fluid normal around the fetus or fetuses. Normally we measure fluid using something called the amniotic fluid index. That means taking a measurement in each of 4 quadrants around the uterus. Sometimes instead we'll just look at a maximum vertical pocket, and this is especially useful if you're doing a quick scan or if you're looking at twins where they each have their own separate compartments of fluid, and you just want to know the deepest pocket in either one. So here, this is an example of a very large amount of fluid. This is a single deepest pocket measurement that's 11. That's a very large amount. Whereas here in this picture, you can see the fetus is right up against the wall and there's very little fluid around this fetus. This would be consistent with oligohydramnios or low fluid. This is an example of how to measure that AFI. So you want to have a sagittal orientation of your transducer and then go in all 4 quadrants. So out of habit, when I do it, I always start in the right lower quadrant, right upper quadrant, then left upper and left lower, and just work my way around the belly. Normally on ultrasound, we'll even put it into the split 4 screens so that I can take it all just in one image to do 1, 2, 3, 4 quadrants. When you're measuring, you want to measure from the top to the bottom of the pocket with that vertical transducer placement. If you start angling your probe, then you can get a false measurement. And you also want to make sure that your pocket is free of any cord or fetal parts. If you measure and it's just full of cord, that's not actually fluid-filled space. And obviously, if there's fetus filling that space, that's not fluid. And especially in cases where the fluid may be low, I'll use color Doppler in order to make sure that there's not a loop of cord here that is kind of masquerading as fluid, but is actually just cord. In order to get that maximum vertical pocket, you want to kind of scan around, look for the area that has the most fluid, and then you again want to measure from the top to the bottom with a vertical transducer placement and make sure that you don't have any fetal cord or parts in that pocket. Next thing you want to know is where is the placenta? Especially in an emergency room setting, if someone's coming in with bleeding, knowing where that placenta is very essential, because if the placenta is up here near the fundus, that's good. But if the placenta is down here covering the cervix, this is not a patient that you want to do a digital exam on, because you could actually put your finger into the placenta and worsen bleeding. So if someone's coming in with bleeding, one of the first things after knowing the fetal number, the presentation, that there's a heart rate, I want to know where is that placenta. So to scan, you just scan abdominally, and usually I'll just start midline and work my way up, and you're looking for the placenta either on the anterior wall of the uterus, posterior, or fundal. It can be either anterior or posterior, but if it's covering the cervix, kind of completely covering that lower uterine segment, that's what we would call a placenta previa. And sometimes we do need a transvaginal scan in order to see how close a low-lying placenta is to the cervix. So to scan, there we go. So this is just an example of scanning through. You started with the fetal head, and you can see up here, this is the placenta. And so as we scan through, here's one placenta, and it actually, for a time, you can say, oh, it actually looked posterior or anterior. So as you scan towards the sidewall, you can see it's actually a placenta that's kind of wrapping around. So it's partially anterior, partially posterior. And by doing that full sweep, you can actually see that it's all connected. There are some cases where you can have what's called a suscenturiate lobe, which is a separate lobe of the placenta. I would not expect a lot of that to come in through the ED. Normally, you just have to continue scanning, and you'll find where those two portions of the placenta match up. And in this case, you can see it's a fundal placenta that just wraps anteriorly and posteriorly. All right, and once you've established all that, so we know how many fetuses there are, we know the fluid, we know where placenta is, we know the heart rate, now we might be interested in saying, well, how far along is this patient? Sometimes patients know the exact date of their period, they've been getting excellent care somewhere, they can tell you their gestational age, but sometimes patients come in and we're just finding out that they're pregnant, and we have to determine their gestational age, or we just want to estimate the fetal weight. We do that by doing fetal biometry. So in the first trimester, you measure just a crown rump length. In second and third trimesters, we use 4 different measurements in order to calculate a gestational age. So those 4 measurements are the head circumference, the bipyramidal diameter, and those are both measured in the head off the same image, and abdominal circumference, and then a femur length. So head circumference, you want an axial plane of the head. You want to make sure you have symmetric appearance of both of the cerebral hemispheres. You want to make sure that in the midline, you have your falx, you have your thalamus here, and then you have your cavum septum pellucidum here in the middle. These all should be in your picture, and you need to make sure that you don't have any of the posterior fossa. So if you see cerebellum back here, that means that your angle is off, and you need to correct in order to get a picture that ideally looks similar to this. To measure the head circumference, we measure it with an ellipse that's measured just outside the edge of the bone, all the way around the head. From that same image, you can also get your bipyramidal diameter. So again, you want that axial plane of the head that's symmetric. You want that fox in the middle. You don't want any posterior fossa. And then you're going to measure the bipyramidal diameter looking at the widest diameter perpendicular to the fox, outside to inside. So outside anteriorly, and then the inside of the bone posteriorly. Next, we move on to the abdominal circumference. So again, we want an axial plane of the abdomen. We want it to be circular. So if you use too much pressure with your transducer, you'll start getting an oblong abdominal circumference. Usually you just need to relieve some of that pressure, and you should get more of just this circular abdominal circumference. Ideally, you want to have the spine either at 3 or 9 o'clock. You want to be able to see the stomach, and then you also want to see the intrahepatic umbilical vein. So we call it the whale's tail. So it's here, imaged here in the liver, and then here's the stomach. You also want to make sure that you can see a rib, but just one rib going all the way around. You don't want to see cuts through multiple ribs. That's going to tell you that your angle is off, and you need to correct that so that you can just see one rib going all the way around. Otherwise, you are getting an oblique cut, and that could overestimate the size of the abdominal circumference. Again, we're going to measure this with an ellipse on the outside edge of the skin all the way around in order to estimate the abdominal size. And then finally, femur length. And especially in an emergent setting, if someone's coming in, they're screaming, you have no idea how far along they are, and maybe you're needing to make a decision of, do I need to transfer this patient? Is this patient viable at my institution? Do we have a neonatal team that can resuscitate here? Do I need to potentially talk about a transfer? The femur length is the one measurement that is often easiest to get and correlates very well with gestational age. Other measurements, especially that abdominal circumference, there's many things that can make it be larger or smaller, both maternal and fetal factors, as well as just user, how well you're measuring it. The bone tends to be easier to see. It's just a straight line that you're measuring. And so in an emergent setting, this would be the measurement I would tell you to go for. So to measure the femur length, ideally you're going to get the whole femur diaphysis imaged perpendicular to the long axis of your probe. And when you measure it, you're going to put the calipers on either end of the ossified diaphysis. So ideally you get a picture that looks just like this. The epiphysis at either end, you can see them, especially later in gestation, but you don't want to include that in your measurement. You just want to put your calipers right here, and that will give you a rough estimate for gestational age. In the third trimester, some of these measurements can be as much as 3 weeks, plus or minus, but it still gives us a ballpark, especially in an emergent setting where we're trying to make quick decisions about where a patient may be best served. So moving on a little bit, so let's say we've gotten our biometry. Now maybe you're even calling in the OB team or an MFM like myself, and we're trying to answer the question, not just how far along is this pregnancy, but how is the fetus doing? And we call that assessing fetal well-being. So this often helps us inform some of our clinical decision making and usually is going to involve your OB team. But on a basic level, this includes a test called a biophysical profile. We also will use Dopplers through the umbilical cord, particularly looking at the umbilical artery. So for the BPP, that assesses the amniotic fluid as well as some of the movements that a fetus makes. And then for the umbilical artery Dopplers, we just use pulse wave Doppler through the umbilical cord to look for ideally a normal waveform that tells us a fetus is doing well. So switching gears a little bit, I want to talk next about some of the OB emergencies that you are likely to come across in the emergency room setting and how ultrasound can help you to triage those patients. So the cases that we'll cover are trauma, hemorrhage, a hypertensive emergency, fetal distress, and then some of the most common, which is just labor, either at term or preterm. So some of the leading causes of maternal trauma include motor vehicle accidents, intimate partner violence and assault, falls, suicide attempts, exposures or overdoses, burns, or drowning. I'm sure you've seen many of these cases in non-pregnant individuals, but They can also happen during pregnancy, and particularly during pregnancy, anyone who's been in even a low-speed MVA should come in for assessment. And we know that unfortunately, intimate partner violence rates actually increase during pregnancy, so you have a higher chance of seeing a patient during pregnancy with these injuries. So when a patient comes in after a trauma, your primary survey should be the same, your A, B, C, D, E, and then we add an F if they're pregnant. So you want to assess their airway, their breathing, their circulation. If mom's not breathing, if mom doesn't have circulation, that means there's nothing going to the fetus, and you want to start with treating mom. But once you've assessed that, then you want to assess quickly what's going on with the fetus. Specifically, how far along are we, and are there heart tones, right? So that goes back to the beginning of the talk, that quick assessment, head down, anterior placenta, fluid looks grossly normal, and I see a heart rate that tap, 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 it's normal. Then you can move on to the rest of your survey. So the secondary survey, that's when you're going to get a little more information. That's when you might think about doing something like biometry. In traumas, the highest complication that we see is abruption. So an abruption is where the placenta starts to separate from the uterine wall. The actual incidence after trauma varies, but is certainly higher than just in the general population who didn't just have a high-speed MVA or even just a fall or a kick to the belly. The rate is still low, but because of this risk, we always want to evaluate these patients for usually at least a couple hour period of time. The higher the force, the greater the chance that that placenta, which is non-elastic and can't contract, can have bleeding behind it in between the placenta and the myometrial interface. The myometrium is a muscle, so during a trauma, it can contract. And if it contracts quickly and the placenta doesn't, that's what leads to the bleeding behind the placenta or the abruption. Sometimes this presentation can be delayed for several hours. Even with the most sophisticated ultrasound, you may not see a small amount of bleeding behind the placenta, and until a few hours pass, you may not see any evidence either on ultrasound, or more commonly, we see just contractions or vaginal bleeding. An abruption is classically a painful episode of vaginal bleeding, usually because there is contractions involved, as opposed to a previa, which tends to present with painless vaginal bleeding because there's just bleeding as the cervix just dilates a little bit. This is a picture which is not common. Hopefully you would not see something like this, but this is actually a placenta here, and there's actually a large amount of bleeding behind it. These images are difficult to get normally because if a patient comes in with this large of a bleed, they are vaginally hemorrhaging and there's a fetal deceleration, so we're not stopping to take long ultrasound pictures to put in a presentation. We get one quick view and then they're being rushed back to the operating room. So this was an example of a case where I had, and we could actually visualize the clot behind it, and this patient then went quickly to delivery. So just as the arrow, here's the bleeding. In terms of trauma treatment, like I said, you always want to treat the patient first. So you want to resuscitate mom because that resuscitation is also going to lead to fetal resuscitation unless you get to the point that you're doing what's now termed a resuscitative hysterotomy. You should have your OB friends with you for that, but that would be if you're actively coding a patient for at least 4 minutes and you haven't had ROSC, then you may think about doing that resuscitative hysterotomy. Delivery in the setting of trauma hopefully is not as you're coding mom, but you may need to deliver for a large abruption, sometimes to facilitate maternal treatment. I've had cases where there was a large trauma, and in order to repair, let's say, a lacerated renal artery, we had to really just deliver the fetus so that the trauma team could then get on to what else they needed to repair for mom. And then you may also deliver for fetal distress. Often that distress is related to an abruption, but there can be other reasons that there may be fetal distress, and that could also be an indication for delivery. So moving on just from traumas to just OB hemorrhage. So we talked about a painful contractions and bleeding. Well, that would be most classically an abruption, but sometimes you can also have some bleeding even during labor from cervical change. You can also have painless bleeding, and this is most commonly with placenta previa. So if that placenta is covering part of the cervix, that can lead to bleeding, and typically those patients don't have severe pain. You can also have bleeding from non-uterine causes. So especially if someone has had a trauma, you can have vaginal bleeding from lacerations. You can also have rectal bleeding from even hemorrhoids or also from a trauma. So this is a video that I've borrowed just showing a placenta previa to show you. So here we're looking at the cervix lower down, and you can see that this placenta is completely covering the cervix as you scan back and forth. I can play it one more time. So as you scroll back or scan back and forth over the lower uterine segment, you can see all you see. Normally we would want to see a fetal head here, but all you see in this case is the placenta. So if you had someone coming in with painless vaginal bleeding and you scan them and this is what you see, again, you would want to call your OB team. You would not want to do a digital cervical exam, and you would want to move this patient towards a labor and delivery ward. Just looking, that would be an abdominal ultrasound. Sometimes you're suspicious abdominally and you want to do a vaginal ultrasound. So this would just be scanning through from a different angle. And again, you can see this is the cervix here. And then this here is the placenta completely covering the internal cervical os. Less common, but equally potentially critical is of a finding is something called a vasoprevia. Normally when an umbilical cord inserts into a placenta, it inserts kind of in the middle of the placenta, but occasionally that umbilical cord will insert at the edge of a placenta or even into the membranes, and then those vessels just track into the placenta. If that happens and it's near the cervix, that's a condition we call a vasoprevia. So I don't have a video for this, but I have a series of pictures taken. So this, just to orient you, is a vaginal scan. This is the cervix. This is the edge of a placenta, and this is the fetal head here. And with Doppler color on, you can see this here is the umbilical cord. You can see the umbilical arteries and vein kind of twisting around each other, which is typical for a cord. You can see it inserting right here at the edge and then coming between the fetal head and the cervix. And this is another example here where the umbilical cord is inserting right at the edge, and we can actually track it down over in front of the cervix here. So when we see a umbilical cord inserting like this and it's going in front of the cervix, this would be another obstetric emergency, because if this patient was bleeding, there's a possibility that the bleeding is actually from the umbilical cord, which is fetal blood. And you can imagine, while mom has extra blood during pregnancy in preparation for delivery, a fetus only has a few hundred milliliters at most of blood at term. So a loss of any of that blood can be extremely dangerous for a fetus, and this patient should go right up to labor and delivery. When you see a patient who is hemorrhaging, first we want to evaluate what is the etiology, because your management is going to vary based on the cause. In some cases, you may have reassurance. You may just admit them for observation to a labor and delivery unit. In some cases, they need delivery, and in some cases, they need emergent delivery via C-section, especially if a placenta is covering up part of the cervix. It's also important to know that pregnant patients can bleed a lot very quickly. And so getting a type and cross for them is essential. If they are losing a lot of blood, we treat them using data based on trauma literature in terms of our transfusion for an obstetric hemorrhage. And then I also always throw in here, if they are Rh negative, remember that they may need RhoGAM, especially if it's a small amount of bleeding that they're having and you're just going to see them and then they're sent home. Moving from hemorrhage to one of our other obstetric emergencies, hypertensive disorders of pregnancy. It's one of the leading causes of maternal morbidity and mortality worldwide and affects nearly 1 in 10 women. It's due to either increased flow or increased resistance, and we'd consider it an emergency if their blood pressures are greater than 160 over 110. These can cause eclampsia, strokes, heart attacks, renal injury, but also abruption, hemorrhage, DIC, some of the things we've been talking about imaging on ultrasound. If you see a patient with a blood pressure like this and they're bleeding, abruption would be at the top of my differential. And again, you want to call your OB colleagues in to assist with treatment. While they're coming down, though, you should reach for your antihypertensives, either labetalol or oral short-acting nifedipine or hydralazine in order to get their blood pressure down. When a patient comes into your emergency room, sometimes when you do that heart rate, you'll see that the heart rate is low, and that can be a sign of fetal distress. Fetal distress can happen for many reasons, usually leading to some kind of mismatch between the amount of oxygen the fetus needs and the amount that they're getting through the placenta and through the umbilical cord. We assess fetal well-being primarily by the heart rate, but also by looking at fetal movement and fetal Doppler, like I mentioned earlier. If you had a fetal tracing, and this is a normal looking heart rate, and then suddenly you see a deceleration like this, you can, and we often do, bring an ultrasound in order to verify, is that really the fetal heart rate? Is it really that low? Are we perhaps just picking up mom's heart rate, because mom's heart rate is typically in the 70s to 80s, whereas a fetal heart rate is in the 120s to 160s. So bringing an ultrasound in often helps us to assess, is this really the fetus? Is there something going on in the uterus that we just can't see without using ultrasound? And where is the next appropriate place to move this patient? In labor, we often use ultrasound in order to assess, again, the fetal lie and presentation and fluid status. Doing this during labor is often challenging because, as this picture demonstrates, the fetus is engaging into the pelvis, and getting these measurements can be quite difficult if a fetus is very low or even moving through the cervix into the vagina, where sometimes that's the case when someone presents. So having your ultrasound at the ready and practicing on patients who maybe aren't in the middle of labor will help you get some of these measurements down in order to then be able to use them in an emergent setting. I next have a couple of cases to go through for examples of when you might use ultrasound in the emergency room setting. So case number one, 16-year-old nulliparous patient who presents. She has good dating. She's 35 and 2. She has a headache and she has severe abdominal pain. So you're going to go in, assess the patient, get a history, and you find out the patient is obese. She's had a history of STIs. She has had her appendix removed. She's only taking prenatal vitamins. She smokes, and she's had prenatal care. She's had 5 visits. At her last ultrasound, the fetal weight was lower. It was at the 15th percentile. So for us, this is a growth that we would call borderline at the 15th percentile. These are her vitals. So hopefully, I know it certainly jumps out to me. It makes my heart rate go up when I see a blood pressure like this. And her blood pressure on repeat, is similar in the 170s over 110s. As you do your exam, she's in some distress. She's really uncomfortable. She has a firm, tender uterus, and she's got pitting edema. So hopefully, after, I had one slide on this earlier, but hopefully all of you are like, oh, I'm really worried about her blood pressure right now because she doesn't have a history of hypertension. And now she has severe range blood pressures that are putting her at risk for strokes and seizures. So you take your ultrasound probe, because you're bringing it with you, because you remember this great lecture, and you set down the probe, and this is what you see back behind her placenta. So that uterus is very tense, firm. She's in a lot of pain. Here's the fetus down here. This is the placenta, and then you see this kind of echogenic collection here that has a little bit of flow off to the side. I put an arrow here just to help you see. This area here is actually a developing blood clot. So you've seen this. You actually had time to measure it. It's a 5.8 centimeter retroplacental heterogeneous and echogenic collection. Flow off to the side, but not in the middle of it. You also saw a single living fetus. We got the lie. It was in longitudinal lie, cephalic presentation. The amniotic fluid looked grossly low. You didn't stop to measure an AFI, but it just looked kind of low. And the heart tones are 90. So putting this all together, things that you should think about doing. Well, hopefully, as you're kind of going through this differential in your head, we've got a patient with a rigid uterus with a tetanic contraction, a large retroplacental clot, high blood pressure. To me, this sounds like preeclampsia with an abruption. So you should be calling OB right away. You want to be repeating her vital signs. So on labor and delivery, we would have her blood pressure going off every 5 to 10 minutes. You'd want to treat her for hypertension. And you also want to anticipate that clot that you saw in the uterus, that's all maternal blood. And so while she's hypertensive now and we do need to treat that, she's also probably about to lose quite a bit of blood. And so this is someone I would send for a type and cross for several units because she's likely already lost several liters of blood behind that placenta and will likely lose more as she is delivered. And then I would call my OB friends and hopefully be moving her towards an OR to be emergently delivered. So diagnosis really is preeclampsia with severe features, including a placental abruption and acute fetal distress. So in this case, ultrasound should give us those clues to say, hey, this, the heart rate is low and I see this mass behind the placenta. Putting this whole picture together, the ultrasound could help change how quickly you treat this patient and where you treat the patient, moving her towards an operating room. All right, so case number 2, we have a 43-year-old multiparous patient. She's a G5 P2216, so she's had a couple preterm deliveries, and she's also had prior multiple deliveries. She presents for abdominal pain, nausea, and constipation. She's obese. She's got PCOS, diabetes, hypertension. She's had 4 prior C-sections. Her medications are metformin and lisinopril. Socially, she smokes and drinks. She has not had any prenatal care. She doesn't think she's pregnant. She's just coming in for this abdominal pain and constipation. She doesn't really know what's going on. So this might be a patient you might not rush into the room like you did with that last patient who we knew was 35 weeks pregnant. You're just kind of sorting out what's going on with her. And as you're gaining some information, here's her vital signs. She has known chronic hypertension. Her BMI is 63. She looks a little dehydrated. She's morbidly obese, but her belly is not acutely tender. But as part of the workup, probably you're going to send a urine HCG and it comes back positive. So you're going, oh, well, now I'll take my ultrasound in, see what I can do, see how far along she is. And here is what you find. So as you're scanning through, you're seeing not one, but 2 fetuses here. So you have one here, one here. You have this thin membrane here. And if I had to put a letter versus a Greek symbol on it, you could see that membrane looks more like a T. So perhaps this is a mono-di pregnancy. So surprise, this is probably part of her nausea and her constipation. It's actually that she has another set of twins. So as you're continuing to scan through, you're scanning all the way through, you're remembering, I want to know fetal lie, number. Now I want to look at that placenta. So you can see there's one placenta here, again, a thin membrane in between. And you can see both umbilical cords kind of inserting right near that membrane insertion on the placenta. If we scan through again. So this helps confirm, I think there's definitely twins. This looks probably like a mono-di pregnancy to me, one large placenta with that thin membrane. Scanning through again. So on the ultrasound, you can also start to assess the fetal lie as this placenta is anterior. This fetus here looks more cephalic with the head lower down. So you diagnose this patient with a twin intrauterine pregnancy, has an anterior placenta, thin dividing membrane with that T sign. You went on and you did some additional measurements and you found, well, they seem to be about 23 weeks in size and they are at this point concordant, meaning both of them have about similar weights. So your diagnosis is monochorionic diamniotic twins. And you say, oh, congratulations, you're going to have another set of twins. You should probably make an appointment with an obstetrician for some follow-up care. So, but the patient says, I've been feeling some pressure and vaginal discharge. And now that I know that I'm pregnant, like I'm kind of concerned about that. I want that checked out before I leave. When you had done your abdominal scan, she has a large BMI. It was very difficult to get some of those pictures, and you really couldn't assess her cervix transabdominally. So you decide to do a transvaginal ultrasound in order to kind of see what's going on with this pressure. On transvaginal imaging, this is the picture that you see. So when we look here, on our other images that we saw in pregnancy with the cervix, we saw a nice long closed cervix with a thin stripe here. In this case, we see membranes funneling down in this U-shaped funnel. We can see a small amount of cervix at the edge. So we refer to that as the functional cervical length, or kind of the amount of cervix that's still held together. In this case, it's extremely small because that funnel of membranes is going all the way almost to the external cervical os. And this would definitely be a cause for pressure, some of that vaginal discharge as well, and also a reason probably not to send her home, but instead to call your good friends in obstetrics down to come and evaluate this patient. So this is... sorry, my picture is covering the words, but cervical funneling, and the patient should be sent up to labor and delivery. All right, so you've got that patient. She's gone up to labor and delivery. They're going to figure out what to do with her, probably keep her in the hospital for a bit. And then another patient comes in to your emergency room. So this is a 29-year-old multip. She's at, quote unquote, 9 months. She's presenting via EMS after she woke up in a pool of blood. So again, you're going to grab that ultrasound, head down there, say what's going on with this patient. Let me start to assess. So as you're kind of running down with your ultrasound, well, we don't really have any past medical history on her. We don't really know if she's had any surgeries. We don't really know if she takes any medicines. And, she doesn't speak English. We don't have the translator yet available, but she has some records from another country in a foreign language. So this has definitely been a case similar to ones I've had on my labor and delivery unit, and could certainly walk through your ED. So you're going down to assess her, and as you're going down, the team is getting vitals, and her blood pressure is 78/42. Her heart rate's 118, rests are 18. She's afebrile, and her BMI is 22. So a couple things that should kind of jump off when you're seeing these vitals. She does appear to be hypotensive. That's a low blood pressure, even for pregnancy. And her heart rate is high. In pregnancy, you can have a heart rate even up to 110 that we would still consider to be okay. 118 is above that. And in pregnancy, seeing an elevated heart rate tells you that she's probably already lost a significant amount of volume. In pregnancy, and she's supposedly 9 months, so near term, your blood volume over the course of pregnancy expands in order to accommodate blood loss with delivery without putting the patient's life at risk. But if a patient has come to you with bleeding and they're already this tachycardic, I would be placing 2 IVs and already calling for blood, because I know that she's lost quite a bit if she's this tachycardic. So when you get to examine her, she's anxious, she's pale, she is tachycardic, confirmed on exam. Her belly is soft but gravid. You're not palpating any contractions, so you're not feeling that tetanic contraction like you did with that earlier abruption. And when you look on a pelvic exam, she has active vaginal bleeding. So things that should be kind of going through your mind in terms of a differential. We could be an abruption, although she's not having pain. She's not having that tetanic contraction. Could be a previa, right? So an ultrasound is going to be very helpful here. Could be some other source of bleeding. Perhaps she was assaulted and the bleeding's coming from elsewhere. Maybe she has intraperitoneal bleeding, as well as some vaginal bleeding. So really, we need to get more information. So you had someone who said, I want to do an exam, and they said, she feels 2 centimeters dilated. Maybe it was breech. I don't know. It didn't really feel like a head. I'm not really sure. We really need that ultrasound in here. You find her records, and you get a similar picture on your scan. And in her records, labeled in English nicely, this is her placenta, her os, and you can see that the placenta placenta is directly covering her cervical os. So likely this is a patient that is bleeding from a placenta previa. As you go into labor with a previa, as the cervix starts to dilate and open, it just moves out from under the placenta. And so all of that area under the placenta that had connections and vascular flow now just starts to bleed, and that blood comes out vaginally. So this presentation of painless vaginal bleeding was suspicious for a previa, and now you've got an ultrasound image to match up with that. So next steps, again, call your OB colleagues. Your ultrasound confirms her diagnosis of a placenta previa. As you're looking on ultrasound, the fetal heart rate is in the 120s, so the fetus still looks okay. And as I mentioned, that tachycardia, made you nervous, so you type and cross, and you also call the operating room so that patient can be moved up with that OB team when they come. All right, so we've taken care of some bleeding patients, taken care of new diagnosis of twins with cervical funneling. And then this next case walks in through your doors. So this patient's a 32-year-old G3 P2002. She's coming in at 30 weeks and 3 days after a motor vehicle accident. She was a restrained driver, so she's doing a good job wearing her seatbelt. The airbags did deploy, and now she's complaining of just some head and abdominal pain. So you go and you talk to her. Her past medical history is significant just for Ehlers-Danlos syndrome. She's had 2 prior C-sections with her other deliveries, and she's really not taking many medications and doesn't have a significant social history. She's had outstanding prenatal care. She's been following with one of the MFMs at your system. She's had 12 visits and so far has had normal scans. So you go to assess her. And when you get into the room, her blood pressure is 88/40. Her heart rate's 110. So again, you remember that recent case you just had come in with the previa. So again, this blood pressure seems a little bit low and her heart rate seems a little bit high. Her rests are 22. She's a little tachypnic. She looks very anxious. She's in pain. She also is not febrile. Her BMI is 19. Her spine has no tenderness. You're less worried about a cervical spine injury from this car accident. And on her abdominal exam, we're skipping ahead. On her abdominal exam, you find some abdominal tenderness. She's got positive rebound, most tender, especially over that lower uterus, but she does not have any vaginal bleeding. So, not sure maybe, what kind of injury she had. The seatbelt was across her lower abdomen, but that rebound is, a little bit concerning. So we're going to do an ultrasound, bring that in as part of our survey. Maybe. Sorry, we're having... Okay, and so you do your abdominal ultrasound exam, and this is what you find. So your probe is just transabdominally, and you see this pocket of fluid here with the fetus. That's so breech presentation, right? We're seeing feet, not a head. And as we look closely, the fluid here that you're seeing is actually pouching out from the uterus. You can see the uterus on either side. And that uterus has separated, likely low here on the uterus at the site of her 2 prior C-section scars, such that the fetus is actually able to push through into this bag of fluid. This should be a concerning finding. Hopefully just hearing me say this is pushing out through the wall of the uterus, that's not a normal finding. And would be consistent with what we would call a uterine dehiscence, or given her pain, a uterine rupture. So from your ultrasound, you report out a single living pregnancy, breech presentation, normal fluid, fetal heart rate's a little low, it's in the 100s. There's a defect in the lower uterine segment with fetal parts protruding. There's no other free fluid noted on just a quick fast scan that you did around the belly. And so we are concerned. Again, you're going to call your good friends in OB. And you're also going to call your OR because this is another time where this patient is bypassing most of labor and delivery, going straight to the operating room. Again, you want to type and cross them because this patient with a uterine rupture can bleed quite a bit, may even be at risk for needing a cesarean hysterectomy, which can be a procedure where a patient would lose quite a bit of blood. So your diagnosis is a uterine dehiscence or rupture, and you've sent that patient off to your OB colleagues. Again, they're really loving you tonight because you're calling them for all these OB traumas. So next, case number 5 walks through the door. This is a 21-year-old G3 P20020. She presents at 37 and 5 and also has some abdominal pain and just kind of greenish discharge for a couple days. She's not really sure what's causing it. So you go and you get some history from her. She's got a history of asthma, obesity, and substance use. She has had just her tonsils out before. She says her only meds are prenatal vitamins and albuterol for her history of asthma. But she does have a history that is notable for heroin use. She's had 2 prenatal visits. She did have a normal anatomy scan, but she's missed a couple visits recently, has had several outreach attempts from the social work department, and has not made it in for care. So you go to evaluate her. You see that she's really normotensive. Her vitals are overall within normal limits. She on the bed, though, is just rolling in pain, in a lot of distress. On abdominal exam, her abdomen is gravid. She has palpable contractions, meaning you just put your hand on the belly and you can feel the whole muscle get tense as a rock, and then relax, and that's happening pretty frequently. She's got multiple track marks on her skin, but no evident abscesses. On pelvic exam, you do not see any bleeding, but you do see this kind of thickish brown-green discharge. So you're kind of calling the OB team back down, but again, you're going to wheel that ultrasound in there, see if you can get some more information for that OB team to help sort out what's going on. So on exam, you see this. So first, couple things that we look at. Well, this looks like a fetus that's probably in a longitudinal lie, breech presentation. It's one fetus. The placenta is anterior up here. She has very little to essentially no fluid around this fetus at all. And then you're going to get your M mode out to do some heart tones. And the heart tones are in the 160s. So you note the oligohydramnios and breech presentation. So as you're seeing this, kind of thinking about that fluid that was coming out for a couple of days, the fact she's contracting and in pain, and as you're calling OB, you're kind of thinking about, well, what could be the diagnosis here? Probably you're going to admit this patient up to labor and delivery. Probably withdrawal. So at our institution, we have a whole program for patients who have substance use disorder in pregnancy. But she also appears to be in labor. And given that oligohydramnios, when she'd previously had normal fluid on a prior scan, I would be very concerned that her water had broken. And that greenish fluid now is actually meconium, which is fetal stool that can pass and often looks green. And potentially she also has an infection if she's been ruptured for a few days and is now just coming in. So she's also going to be transferred up to OB, and I think you've done enough on this shift. You've had some really great OB cases. Your OB team says that's enough. We don't want you to call us anymore. So as you're kind of sitting down and reflecting, you think about, well, what are some of those great uses I had for ultrasound in obstetric cases down here in the emergency room? Well, point of care ultrasound can really be used to help determine fetal lie and presentation, fetal number, biometry in cases where you need to know the fetal gestational age or weight. Helps you determine the cardiac activity, the amniotic fluid volume, and placental location, all of which are really critical in assessing what is going on with a patient and how quickly they may need to be assessed by the obstetric team. So in the emergency setting, you evaluate the presentation, number, looking if they're bleeding, if there's evidence of a placenta previa or abruption, or if there's evidence of labor or rupture of membranes, which would be presenting with low fluid. You want to call your OB team early and often, and remember, send a type and cross for pregnant patients with a hemorrhage because they can bleed a lot very quickly and need that resuscitation. All right. Any questions? I don't know if we can take questions in this format. otherwise, thank you very much for having me.
So I had a question. That case number, I think it was number 4 with the Ehlers-Danlos uterine dehiscence was terrifying.
Yes.
Yet probably the coolest OB ultrasound I think I've ever seen. I'm assuming that happened at the site of the previous C-section scar. Is that correct, or is there something different there?
Yes. Ehlers-Danlos is actually a risk factor for just a spontaneous uterine rupture. So anytime you see someone with abdominal pain and pregnancy and a connective tissue disorder that should be on your differential, it is a very rare presentation. Makes a great case for something like this, but it can happen. And these pictures are not from that case, but we actually had a case here in the past that I was involved in who had a spontaneous uterine rupture. So it can happen and often presents like that with pain out of proportion to whatever event may have preceded their coming in and having a just high suspicion for something going on. And ultrasound really plays an important role in those cases because you get pictures potentially like that.
That was pretty impressive. And I assume that the reason why this one happened is because it's a connective tissue disorder. The uterus is probably a lot more fragile than would otherwise be. Is that correct?
It is, although in a patient who's had multiple prior C-sections, you can have a very thin lower uterine segment. Sure. So we'll see it, when we go back in for a repeat section, that lower segment is actually like paper thin, like tissue paper thin. So typically they don't present like that, but you can have thinning even in the absence of connective tissue disorder if there have been prior myometrial surgeries. So most commonly a C-section or a myomectomy.
Gotcha. Well, I think that's been a very great summary. You have one slide at the end after your summary slide that I think maybe we'll just cut to that here just for a sec.
Sure. Are you able to?
Yeah, go for it right there. So I thought this was helpful, a little hidden gem kind of at the end of the presentation here. But for us in the emergency department, who maybe don't do this every single day, it's helpful to have just kind of a framework that we can just hang our hats on and kind of walk ourselves through as we do these scans. And I know for us, we have a great relationship with the OB service, and a lot of the patients that are in the second and third trimester just bypass the emergency department and go straight up to L&D. And so we don't see a ton of these, which means, our skill set isn't maybe as immediately reflexive as we'd like it to be. But I thought this was really helpful to think through what are the fundamental components of that point of care ultrasound in the emergency department. So fetal lie and presentation, cardiac activity, fetal number, AFI, placental location, fetal biometry. During the lecture, I was trying to come up with an A, B, C, D, E, and I got close. I have cardiac activity, or A for activity, B for biometry, C for placenta or connection. It's a stretch, right? D for direction, fetal lie. It's another stretch. E for fetal number, which is expected number, big stretch right there, and F for fluid. It's what dumb ED doc can figure out. But regardless, if you kind of think through these 6 different components, it can serve as a little bit of a protocol for how we should be scanning these patients when they come in. And what I like about it is it kind of walks us step by step through the various different emergencies that can happen in these patients. So I found this lecture to be very helpful, as did some of the other people that were on the live forum. So thank you for being here and for presenting that for us. For the rest of you guys who are joining us on the YouTube channel, hope you guys enjoyed this one. If any of this you need a little bit more background material, we have all of the OB first trimester lectures up on the website, or up on the YouTube channel, the normal, the abnormal, the not quite normal but not quite abnormal lectures that we gave this spring. I also have a fetal biometry lecture, so if you want to dig a little bit further into how to do a BPD or a head circumference or femur length, check that out in the OB playlist. We've got some material about how to do that. And as always, there's some OB shorts that we've put up. There's little key findings for ultrasound related to obstetrics. We got one coming out next week about the first trimester. We had one last week about how to identify little teeny tiny little babies. So all sorts of good information there. If you have not yet subscribed, please do. Hit that subscribe button down below, hit the like button, the notification bell. All these are tools that we can use to get this information into your hands more efficiently. And so I think we'll wrap things up here. Next week, we are going to transition for 2 weeks to wrap up this year to do a little less ultrasound, but a little bit more practical how to teach. So Dr. Werner is going to come back and talk about how to give a presentation using the analogy of a pie. You're not going to want to miss that. It's going to be very tasty, if not educational. And the following week, I'll wrap up the whole semester with 3 tools that I think are important for success in academic medicine, things that can be helpful as we teach, helpful for our fellows as you try to learn and incorporate and do all this knowledge synthesis and translation in ultrasound, things that can set you on a path to success. So hopefully you join us for those. I'm excited to hear Sandy's lecture. I'm excited to give the following one, and then we'll take the summer off and restart this whole thing again next fall for more great material. But let's wrap it up here. Thanks for joining us, and we'll see you guys next time on Ultrasound Grand Rounds. Thanks. Bye.